Welcome, everyone. We're so delighted to have you join us here this evening for our first ever virtual MedTalk event, COVID-19 Vaccines and Treatments, What We Know and What We Don't, presented by the UCF College of Medicine. My name is Carly Thomas, and I will serve as your moderator this evening, and I'm with the UCF College of Medicine. Before we start this evening's presentation, a few housekeeping items. During the presentation, please make sure your microphones are muted. If you have a question during the presentation, please feel free to type that question in the chat box that will appear in the bottom of your screen. We will be sure to go over your questions during the Q&A portion of our presentation. Now for the fun part. I'm delighted to introduce to you someone who needs no introduction, a physician, educator, and visionary leader who has built our medical school from the ground up, our Vice President for Health Affairs and Dean of the UCF College of Medicine, Dr. Deborah C. German.
Well, good evening, everyone, and thank you, Carly, for that introduction. Welcome to this year's inaugural UCF MedTalk. This is part of our new Health Symposia series. We're so glad you've joined us this evening. This series is designed to bring the best research and discovery from our college directly to our community. Now, some of you may be new to us and may not know about our medical school, so just a few basic facts. We were founded in 2006. Our first class started in 2009, and we've enrolled 12 classes. We're located in Lake Nona, and we have 489 medical students, that's 120 per class, and over 3,000 undergraduate and graduate students in biomedical sciences. We have almost 500 residents and fellows studying all across Central Florida. And our faculties, employed faculties, number about 150. Now, we have a new teaching hospital and cancer center that will open in early March of this 2021 year. And our faculty are engaged in teaching, caring for patients, and research in so many areas of medicine, one of which is infectious diseases. Tonight's presentation is a topic that is likely of intense interest to all of us, COVID-19. We're excited to begin the series with both a clinical and a lab research perspective that will touch on the treatment and the vaccine questions that are so important to understanding what a bright future could look like and how we will get there. So thank you again for joining us tonight, and I hope you will enjoy the presentation. I look forward to seeing you at the next event.
Thank you, Dr. German. Thank you for that great introduction. Without further ado, it's my pleasure to introduce to you tonight, and we're delighted to have our speakers here, Dr. Jelena Catania, who is Assistant Professor of Internal Medicine with the UCF College of Medicine, an infectious disease specialist and clinical director for microbiology lab at the Orlando VA Healthcare System. I'm also delighted to introduce to you Dr. Kai McKinstry, who is Assistant Professor in Immunity and Pathogenesis Division of our Burnett School of Biomedical Sciences, which is a part of our UCF College of Medicine. We're going to start this evening's presentation with Dr. Catania.
Thank you very much for the introduction. And thank you very much for the opportunity to speak with you this evening about current therapies used in treatment of patients with COVID-19. We have come a long way in treating this infection from the beginning of the pandemic in March, when very few ineffective therapies were available, to a growing armamentarium on novel therapeutics with new knowledge and experience being added daily. As an infectious disease specialist, I have had the opportunity to treat many COVID-19 patients at the Orlando VA located in Lake Nona. Tonight, I will share that clinical experience as well as the scientific evidence that supports use of some of these therapies in our fight against COVID-19. Since we have a mixed audience of healthcare workers and other professionals, I will do my best in trying to explain how to interpret some scientific data. I think it's important to dig a little deeper into primary literature beyond the flashy headlines to understand why and how our current treatments are being used. I have no conflicts of interest to disclose, but I do have to mention that the views I will be expressing tonight are my own and do not reflect those of my employers. To start, let me remind everyone that coronaviruses are a large family of RNA viruses, some of which can cause respiratory infections in humans, ranging from the common cold to MERS, which is the Middle East Respiratory Syndrome, SARS, severe acute respiratory syndrome caused by the virus SARS-CoV-1, and most recently, coronavirus-associated disease 2019 caused by SARS-CoV-2. COVID-19 patient presentations can range widely from asymptomatic to life-threatening infections. It is not clear at this time why some people can remain asymptomatic but test positive for the presence of high viral loads in their respiratory tract. And of course, by the virtue of the fact that the presence of virus does not cause clinical disease, it is difficult to obtain the exact statistic about how many people are infected. So this is just an estimate based on contact tracing case series studies. Data presented here on prevalence of disease based on severity comes from large retrospective reviews of hundreds of thousands of patients from China and Italy. But of course, these statistics are highly dependent on age, geographic location, ethnicity, etc. Mild to moderate disease also has a wide range of symptoms from fatigue to clinical pneumonia, but severe disease is specifically defined as having low levels of blood oxygen, usually at 94% or lower at room air. Critical disease is considered when respiratory failure occurs, necessitating intubation and mechanical ventilation, usually from widespread inflammation in the lungs called ARDS, or acute respiratory distress syndrome. The strategy in combating this disease is to attack multiple aspects of viral pathology, meaning how the virus causes disease in human tissue, mostly the lungs. Antiviral treatment directly affects viral particles and prevents them from replicating. Anti-inflammatory medications such as steroids dampen the immune system, which can overreact and cause unnecessary inflammation and tissue destruction. At the same time, exogenous antibodies can be administered early on in the infection before our own immune systems have revved up to make adequate supply of antibodies that can neutralize the virus. Additional strategies include prevention and treatment of complications such as administering blood thinners, as this infection has been shown to increase the risk of blood clots, as well as administration of antimicrobials in case of a superinfection. Given that we only have 15 minutes for this portion of the talk, I will only be able to briefly discuss a few select, most commonly used therapies. The first drug I would like to discuss tonight is remdesivir, which prematurely terminates a step in viral replication. With this graphic, I am trying to illustrate the little, dare I say, controversial trip remdesivir took on its journey to helping patients with COVID-19. Back in May, the Federal Drug Administration issued an emergency use authorization, or EUA, that allowed use of remdesivir in hospitalized patients with severe COVID-19. During non-pandemic times, FDA requires manufacturers to submit extensive patient data from clinical trials for drugs in development, proving their safety and efficacy. During a pandemic, those processes can be fast-tracked so that drugs do not necessarily need to be FDA approved to be brought to market. Of course, by the same token, less knowledge and experience about safety and efficacy is available, so that these drugs are usually used in the most sick of patients when other options are not available. In August, FDA expanding the EUA to allow use of remdesivir in any hospitalized patient, irrespective of severity of disease. Shortly after, the National Institutes of Health, or the NIH, updated their COVID-19 guidelines. These guidelines are a fluid document managed by dozens of NIH experts who analyze the available literature, debate results and study limitations, and make recommendations for practicing clinicians to use. In this case, based on available evidence, NIH guidelines recommend remdesivir use for hospitalized patients who require supplemental oxygen, meaning severe disease, and state that insufficient evidence is available to make recommendations for or against its use in patients who are mildly or moderately ill. Infectious Disease Society of America guidelines, IDSA guidelines, made up of dozens of infectious disease experts throughout the country, made similar recommendations, but they went a step further as to not recommend remdesivir use in mild and moderate cases. So let's examine the evidence. The most robust data comes from the preliminary report of a multi-central trial of over 1,000 people conducted in 73 sites in the United States, Europe, Asia, and Mexico. Here I made a graph using study results that shows median days to recovery on the y-axis and severity of disease on the x-axis. The primary outcome of the study was time to recovery, defined as discharge from the hospital or continued hospitalization without need for supplemental oxygen or ongoing medical care. Overall, remdesivir resulted in faster time to recovery, 11 days for remdesivir and 15 days for placebo. This result was shown to be statistically significant, meaning that there is a 95% confidence that the difference in days was not due to chance alone. However, when the data was further analyzed, the difference was not significant for patients in the mild and moderate categories. And within the severe category, it was most significant in patients who required low levels rather than high levels of oxygen support. Once disease became critical, the benefit of treatment with remdesivir in terms of days to recovery could not be shown in this study. I also wanted to show you this graphic of remdesivir effect on 14 days mortality. As you can see, there is a trend toward decreased mortality in patients taking remdesivir. Overall, 7.1% of patients on remdesivir died compared to 11.9% taking placebo. But this result is not statistically significant, meaning that the difference could be due to chance alone. Regarding my personal experience with remdesivir, I cannot isolate this one drug from all the other treatments currently available for treatment of COVID-19, as our institution was not part of a remdesivir clinical trial. But what I can say is that therapies we currently have available in the care of patients with COVID-19 seem to be much more beneficial compared to the standard of care in the beginning of the pandemic in March.
Thank you.
Thank you. I had a hard time moving along. So we're moving right along here to dexamethasone, which is a steroid recommended by IDSA and NIH guidelines for use in patients with severe disease. The data this recommendations came from, and I don't know why I can't, okay, there you go. The data for this recommendation came from the recovery trial from the UK of over 6,000 people. This graph shows reduction in mortality at 28 days on the y-axis and severity of the disease on the x-axis. It shows that the most critically ill patients who are on the ventilator and would otherwise have 40% mortality were able to reduce it by 35% with this low-dose steroid. Severely ill patients requiring supplemental oxygen who had baseline mortality of 25% still had a 20% reduction in mortality with dexamethasone, but as we compared this to the previous group, that benefit was smaller. Based on these results, it was calculated that 1 death could be prevented by administering dexamethasone to 8 ventilated and 25 supplemental oxygen patients. Interestingly, patients who did not require respiratory intervention did not have a statistically significant decrease in mortality at 28 days. Now introducing convalescent plasma, which works by passively transfusing neutralizing antibodies against SARS-CoV-2 virus into patients whose immune systems are still struggling to produce an effective antibody response. This process entails collecting blood products from donors who have recovered from COVID-19 and transfusing them into sick patients. This special procedure, called apheresis, enables collection of plasma, which contains proteins such as antibodies, gamma globulins, coagulation factors, etc., while returning red blood cells and other blood components to the donor. As we have done with other treatments, let's examine the recommendations and supporting evidence on convalescent plasma. FDA has issued an EUA for its use in hospitalized patients in August. Prior to this, convalescent plasma was only available as part of a clinical trial, and many institutions, including ours, participating in the Mayo Clinic open label multi-center national expanded access program. NIH and IDSA guidelines currently state that there is insufficient evidence to recommend for or against using convalescent plasma for patients with COVID-19, and this is why. This table is reproduced from IDSA guidelines that list some of the current studies reporting on the efficacy of convalescent plasma, their results, and their limitations. As you can see from this column, the experts at IDSA judged the listed studies to suffer from serious to very serious risk of bias, even including the 2 randomized trials that are in the first row on top. The others are observational studies, meaning that the patients were not assigned to treatment versus control or placebo arms in a random fashion, which can lead to confounding results. In addition, the results of the only 2 randomized trials show that the effect, in this case mortality, was not statistically significant, as patients receiving convalescent plasma could experience a wide range of outcomes, from a 66% decrease up to a 10% increase in mortality based on the study results. Luckily, in the largest safety study of 20,000 patients analyzed by the Mayo Clinic as part of their expanded access program, the risk of any adverse effects in patients receiving convalescent plasma was very low, less than 1%. Since we just discussed how passive immunity can be used in the treatment of COVID-19, I wanted to also mention the new kid on the block that has received a lot of media attention in the recent days. This is the new antibody cocktail from Regeneron, which is not currently available on the market. It contains 2 laboratory engineered antibodies that bind to different parts of the spike protein of the SARS-CoV virus, which plays a crucial role in penetrating host cells and initiating infection. Here you can see a graphic of how the Y-shaped antibody attaches to its target to exert a therapeutic effect. There's ongoing trial, clinical trial expected to enroll over 2,000 people. Very early results reported in a press release and not peer-reviewed yet show that the drug is effective in decreasing the viral load, but no clinical data on the patient's outcomes is available at this time. Here I have listed some of the other drugs targeted toward COVID-19 treatment that have either not shown any significant benefit in treating this infection, and in some cases have even shown harm. In the interest of staying on time, I will not have a chance to discuss these in any detail, but here I listed them for you. I also wanted to touch upon treatment after COVID-19, or what's called the post-COVID-19 care. Some people may continue to experience lingering symptoms referred to as the post-COVID syndrome or the long haul syndrome after acute illness. The syndrome is not clearly defined, as it is just beginning to be described in the literature. But what we do know is that many people have persistent symptoms after initial onset. A recent CDC telephone survey of 274 people reported that 35% of patients described not being back to baseline at 2 to 3 weeks from initial positive test. Similarly, in a study from Italy of 179 inpatients, reported that most people were still symptomatic at 2 months post-initial diagnosis. There are also some studies about rates of hospital readmissions for worsening symptoms after initial improvement. Post-COVID-19 care is variable across institutions and depends on specific patient needs. In some cases, patients need to be discharged from the hospital on supplemental oxygen, additional steroids, and blood thinners to prevent blood clots. In other cases, patients may have suffered heart or kidney failure as a complication of COVID-19 and now need ongoing specialty care. For others, chronic shortness of breath may need to be managed with breathing exercises, counseling for anxiety management, etc. The purpose of my talk was to give you a glimpse into current standard of care of COVID-19 treatment in the US and the evidence behind some of the drugs in the spotlight. We mostly focused on what to do once patients already fall ill. But I wanted to close with a more optimistic message of what we can all do to try to prevent being exposed to this infection, which includes not touching your eyes, nose, and mouth, avoiding close contacts with people who are sick, staying home when you're sick, covering your cough and sneeze, using a face covering, cleaning and disinfecting frequently, and performing frequent hand hygiene. Thank you very much for your attention, and I'll be happy to answer any questions at the end of the talk.
Thank you, Dr. Catania. We appreciate that. And as a reminder, if you do have questions, we could put them in the chat box to where we will be going following the presentation. Next, I'm going to introduce Dr. Kai McKinstry, who will talk to us about COVID-19 and vaccination.
Great, thanks Carly for the introduction. Thanks to everyone for spending some time with us this evening, and thanks to Dr. Catania for getting the evening off to a great start. So I'm going to talk to you a little bit today about things to consider for vaccination in general, and then share some insights from our lab's work on influenza viruses and how that might relate to COVID-19, to COVID-19 vaccines. I don't seem to have control. Great, yeah. Well, maybe someone can just change them when I say next. But I like to start with this slide because it actually has some interesting history and information about vaccines. And this is a depiction of what it must have been like for Edward Jenner delivering the first vaccine against smallpox, taking from, on the right of the picture here, some material from a lesion of a milkmaid that had cowpox, which was a closely related virus to smallpox, but caused a much milder disease, and administering it to this child here as a way to produce immunity against smallpox. And of course, vaccination is derived from the Latin cow, vacca, which comes from the history of smallpox being used, cowpox being used to vaccinate against smallpox. Next, please. So how do vaccines work? Dr. Catania also introduced already the concept of antibodies, so I'll just go over it really briefly. So the idea of vaccination basically is to expose us to either a harmless form of the disease, or in many more modern approaches, even just one protein or even a part of a protein of a pathogen. In some cases, even two, just nucleic acids, in order to generate antibodies that will then be present in our bodies and offer basically a shield that will pre-exist, and then when the actual pathogen invades our body, we will have a preformed layer of defense, and by that definition, we will be immune. Next, please. So the most important antibodies are, of course, neutralizing antibodies, and that term just basically means an antibody, which is a small protein that can latch on very specifically to a defined determinant. A neutralizing antibody would be one that recognizes a site on a pathogen that's important for it to enter our own cells, and especially for viruses that need to get into our cells to replicate in order to reproduce. If we can stop them from getting in the first place, that's the best way to promote sterilizing immunity. If you could just hit next, please. Yeah, so if we don't have antibodies in our system, a susceptible individual then has nothing to block the virus from entering into our cells, and thus this person on the right-hand side would develop disease, whereas on the left we'd be immune. Next, please. So who makes antibodies? Well, B cells are a specialized cell in the immune system whose job it is to make antibodies. And B cells do that very well. You can see on the diagram here that they have receptors, a BCR, which is basically a surface version of antibody that recognizes a pathogen. And then, if you please next, once they recognize it and become activated, then they spit out lots and lots and lots of copies of this antibody. But for the best antibody responses, B cells need to get help. And they get help from a cell type called a CD4 T cell. Oops, back maybe a little. I'm sorry. And CD4 T cells are often referred to as helper cells because their job in the immune system is primarily to offer a variety of cell surface and soluble signals to help B cells make not only better antibody, but very long-lived antibody. And so vaccines should be thinking about being able to stimulate not only B cells, but also CD4 T cells. Next. And this data I pulled out of an older study, but an interesting study by Mark Slifka's group, where they were able to access serum samples from workers at a primate facility that had to be checked routinely for any kind of sign of illness that they might have picked up from the primates. And so this group was able to go through retrospectively the serum for over about 26 years and look for the half-life or the persistence of antibodies against commonly vaccinated diseases. And on this table here in the red box is showing the years of the half-life of the antibodies in people against different diseases. And you can see that for some, vaccination really produces an incredibly long-lived protective state in terms of antibodies. So you can focus maybe on measles, mumps, rubella, which is a very effective and common childhood vaccine. We can see the antibody half-life from thousands of years to hundreds of years. Whereas if you look at tetanus, here's something, 11 years is still pretty good, but many of you might have experienced the need for a tetanus booster, and that's why. Next, please. So now I just want to quickly introduce influenza virus as a means to begin discussing some of the hurdles that may be facing a COVID vaccine. So influenza, I just put up a diagram here and want you to take special note of the neuraminidase and hemagglutinin proteins that are on the coat. These are the receptors of the virus that are needed for it to get into and out of cells. So they're the targets of neutralizing antibody. The other reason why it's interesting to talk about influenza is because the first vaccine was developed in the 1940s. And so we've been working on this a long time. And influenza has a couple tricks up its sleeve, including two mechanisms whereby it keeps changing. And that's one reason why we need to get an annual vaccine to target the new version that's circulating. Next little click. The virus also has so-called internal proteins that are expressed once the virus infects human cells. And that's going to become interesting later on. So just remember that there are also internal proteins. Next, please. So again, just to reiterate, the idea of antibody-mediated immunity would be then that you are vaccinated, say, against this strain of influenza on the top in the middle that has a defined neuraminidase and hemagglutinin. If you then come into contact with that same virus later in the season, you would have strong protection because the neutralizing antibodies would prevent infection. However, if you came into contact with a different strain of circulating flu, these neutralizing antibodies wouldn't match the different HA and NA proteins, and thus the vaccine would be of limited use. And indeed, this is what happens when pandemic strains arise, because even though people get an annual vaccination, it's not protective against the pandemic strain. Next, please. So, and if you just hit the mouse again. Yeah, so this is a graph from CDC showing the relative effectiveness of influenza vaccines over the past several years. And you can see, troublingly, even the best years were only at about 60% efficacy, and some years it plummets all the way down to the teens. And this is for a variety of reasons, including issues with manufacture and targeting the right kind of strains to include in the vaccine formulation. And next. Obviously, it's suboptimal. Yeah, next. So one of the reasons too beyond that, and this is a very interesting study that looked at the efficacy of the influenza vaccine during the season. And you can see in the graph here at the left-hand side, when you look about 2 weeks out after vaccination, the effectiveness of the vaccine was hovering in this season around 35%. But if you go out to 150 days or about 5 months, that vaccine efficacy basically plummets to zero. And so this shows that even if a vaccine is able to generate protective antibodies, the duration of the optimal window of protection can be short. And one of the reasons it can be short is if the vaccine is unable to induce the pathogen-specific T cells and thereby offers only very weak CD4 help for those B cells to make long-lived antibody. Next. And so this might have relevance, high relevance to COVID-19. And this is just a headline talking about a study that came and looked at the half-life of COVID-19 specific antibodies that were in patients and found, as you can see in the text below the headline, that they had a half-life of about 73 days. And then they nicely point out to us that means half of them would be gone after that much time. But that's a very surprising finding. It suggests that even during natural infection, COVID-19 is not stimulating the kind of T cells that are needed to help and make a long-lasting antibody response. And this might be why some patients have prolonged symptoms or become reinfected. Another question that this raises, if you look at the headline, it says antibodies may fade fast, but protection may not. So what's responsible for immune protection if not neutralizing antibodies? Next. And again, I'll go back to discussing influenza, where in animal models and human studies, we've now uncovered a very strong protective mechanisms that is mediated by T cells and not by antibodies. And here again, if you look at the diagram in the middle, if you were to be immunized in such a way to generate T cells against one strain, the nice thing about T cell immunity is it can provide protection against a variety of strains because it targets the internal viral proteins that I briefly mentioned before. And this is because these internal viral proteins are under a lot less immune pressure than the external proteins. And so T cells tend to recognize those conserved epitopes. This is exciting a lot of people as a platform for making better vaccines against influenza, even universal vaccines that could protect us against multiple different strains, and you wouldn't need an annual formulation. Next. So how do T cells protect? And of course, this is an incredibly complicated topic in the field, but I'll just briefly introduce three major mechanisms. The first on the left-hand side is by activation of so-called antigen-presenting cells that themselves make a lot of inflammatory factors that call in cells of the innate and adaptive immune system to a site of infection. And it's these cells that then participate in defense against the virus. The second mechanism is through the production of factors like interferons. So you see IFN gamma there. And interferons got their name because they were discovered to interfere with viral replication. And so if T cells get into the site of infection and produce these factors, they can induce an antiviral state and reduce infection. And finally, it's through the killing of virus-infected cells. So again, the virus needs to replicate in our cells to really induce a severe infection. And so if we can kill those factories, we can limit infection. And T cells can do all of these things. Next. And there's some evidence that's coming out, and this is a very recent paper that was just published, finding that there's robust T cell responses in individuals that have recovered from COVID, and even some evidence that patients with milder disease have stronger T cell responses. And so this is very encouraging and suggests that memory T cells may be very important in protecting against COVID. And if you induce a good memory response, it might be very good to prevent reinfection. And there's a lot of questions, though, that still need to be answered. The first is, by what means the T cells protect? Is it by one of those three mechanisms I just introduced or others? And the challenge will then be for vaccines to optimally prime memory T cells that can do those things and can synergize then with antibody to give us strong protection. Next. And this is going to be a challenge, and it's really a challenge in the field, is understanding how T cells are primed in order to mediate those different kinds of protective mechanisms, and how to make sure that they persist long-term in the body. That's for a couple reasons. The first is B cells were discovered in about the 1950s, and antibodies were even discovered in the late 1800s, 1890s. But how T cells really are activated and work wasn't really worked out till the mid-70s, early 80s. And so just now, we in the field are trying to uncover really critical signals that control memory T cell location. There's some evidence that you really want them at sites of infection. So for COVID in the lung, control the longevity of the cells and control their functions. And this diagram I threw up to be incomprehensible, because that is sort of the state of things. People are all over the world are looking at all of these different factors in controlling T-cell fates. Next, please. And this is my final slide just before the conclusion, just to introduce the idea of timelines in vaccines. And this comes from a study here. And if you look, each of these bars represents a journey from, on the left, when the causative agent was identified, to the right, where you see a green line, when the first vaccine was licensed in the States. And you can see by looking at the year's duration here, it can be quite a long time. And sadly, if you look the first two lines and the final line with malaria, tuberculosis, and HIV, we're still hunting for an effective vaccine. And this is reflective of a lot of complications along the way. Next, please. So in summary, some vaccines provide lifelong antibody-mediated immunities and others don't. And that depends on the type of the vaccine. It depends on the role of antibody in protection, and it depends on the ability of a pathogen to avoid neutralizing antibody. So just for example, with tuberculosis, that's a bug that lives inside cells. And so even if you make a lot of antibody to it, the antibody would never see it because it's inside of cells. And secondly, vaccines should really try to induce T cells and B cells together. And this is important, one, to provide better help to B cells to generate better quality and long-lived antibody, and also so that T cells can help for synergizing mechanisms of protection that can also be redundant and improve vaccine coverage. And so I'll just leave with the message that we've never had such a concerted effort around the globe to try to develop a vaccine. And I hope those timelines in the graph before will be much shortened by this global effort to try to uncover an effective vaccine. And I thank you for your time, and then take any questions.
Thank you, Dr. McKinstry, and also thank you, Dr. Catania. We do have several questions that have been posed in our chat area, so I will start going through those, and feel free to answer them, either one. The first question we've got: we've heard a lot lately about vaccines for adults, but not much for children. As a new parent, 4-month-old daughter, what can and should we expect for vaccines for children, particularly babies? I work at a university among students, and I'm very conscious of the potential for bringing this virus home. I'm hoping a vaccine will be available for my whole family.
I would throw that to Dr. Catania. I think that's obviously the hope for everyone, but I think that's above my pay grade.
Well, I am not intimately involved in vaccine development or allocation, but what I can tell you is that the CDC, this is just, I'm not intimately involved with this, so this is just something that any of us can look up on the CDC website, but there are some discussions within the CDC about how, when the vaccine becomes available, how it will be allocated. There's some work groups that have put out presentations about phases of vaccine allocation. So, and these are just suggestions, nothing's been officially put forth, but from what I understand, phase 1A may be vaccinating critical healthcare workers and patients or people who live in nursing home facilities or in homeless shelters, something like that. And the next phase would be vaccinating more immunocompromised patients and older population that may be with comorbid conditions that may be at higher risk for complications and severe disease. And the next phase would increase to include maybe all older adults and other critical workers that may not be in healthcare. And then the following phase, which would be phase 3, would include children and then all adults. Most of the clinical trials early on do not include children for testing the efficacy and more importantly, side effects and what dose would be appropriate for children. So whatever vaccine becomes available for on the market, I would imagine it would first be available for adults and then later on for children.
Okay, thank you very much. Next question, and this may also be for Dr. Catania. Seems there's so much speculation as to how effective the vaccines will be. Is it possible that the therapeutics will be at least as important as the vaccines, or even more so in the long run?
So let me see if I understand the question, and then maybe it could be reformulated if I'm not answering it. But both vaccines and therapeutics, medications, once the disease is present for treatment, have to undergo clinical trials or some kind of clinical studies to show whether they're effective and safe to be given. So there's a lot of speculation. I would say there's a lot of speculation about efficacy of therapeutics. Some of them were used early on and were shown later with more experience not to be effective and actually to be harmful. Some of them that we are using now, we might learn in a few months or a few weeks that they shouldn't be used based on new data that's not available now, but they may be published in the coming weeks and months. So there's a lot of speculation here, and we are doing our best to use what is available, mostly not to cause additional harm and hopefully help as we go along. But I think new data will elucidate whether what we're doing now is correct or not. We just have to see and use our judgment to do the best by our patients. But if there's a possibility of a safe and effective vaccine, then it's always better to try to prevent the disease before it happens rather than wait for the disease to be developed so that it can be treated.
I'd like to point something out with regard to that question. A vaccine is for prevention, and the therapeutics are for cure once you've contracted the disease. So it's not one's better than the other. They attack the disease in different ways. One prevents you from getting it, and the other treats you after you've been diagnosed with it.
Okay, thank you for clarifying. I might have missed that was the point of the question. Thank you.
Okay, thank you. I have the next question here, and I believe this is actually from Dr. German. Steroids are relatively strong anti-inflammatory drugs with some side effects. Are there any studies to suggest that non-steroid anti-inflammatory drugs could help either prevent severity or help manage the post-acute phase lingering symptoms?
So that's an interesting story about NSAIDs. So early on in the pandemic in March, there were some non-peer-reviewed case reports coming out of Europe stating that maybe NSAIDs were causing more severe disease, or maybe not causing, let's say maybe associated with more severe form of COVID-19 in patients who are taking NSAIDs as opposed to those who are not. And so there was a lot of confusion in the beginning where if patients were initially on NSAIDs, doctors were trying to discontinue them just to prevent patients from developing potentially developing more severe disease. And the reason behind that was that maybe there was this, there's the ACE inhibitor receptor. The ACE receptor is the receptor to which the SARS-CoV-2 virus attaches to the cells and enters the cells. And this receptor is found to be revved up or increased in the setting of patients taking NSAIDs. So there was a belief that maybe in those patients taking NSAIDs, they would have more receptors and therefore a bigger opportunity for SARS-CoV to infect their cells. Now, those were just initial reports early on. There have been studies done since then, and no association with worse outcomes has been published in the story of NSAIDs. And also no improved outcomes in those taking NSAIDs either. But I think the NSAIDs will still kind of stay in the back of clinicians' minds, a little bit of a worry and a pause when thinking about NSAIDs and using them for treatment of COVID-19.
Thank you. And it looks like, Dr. Catania, we have a follow-up to the earlier question, a clarification, if you will. It says, will the therapeutics possibly play a larger role depending on vaccine efficacy?
So if I think they are two separate, as we mentioned before, there are two separate ways to attack the pandemic. With the vaccine, we're trying to prevent the disease, and with the therapeutics, with the medications, we're trying to treat the disease. So research in both of those areas, I think, is occurring in parallel, regardless of one and the other. So just like with influenza, we have the vaccine, but there are still therapeutics that are being used and developed in case the vaccine is not effective and the patient does succumb to the disease. So I think there'll be an ongoing additional drugs that will be brought to market for COVID-19 as we see in the future.
Thank you. And I think we have one for Dr. McKinstry here. Are there any specific UCF labs contributing to COVID therapeutic research or vaccines?
There are a number of internally funded projects going on in different labs that are specifically looking at different aspects of COVID infection and trying to leverage faculty strengths on that question. I believe there may also be a couple externally funded grants looking specifically at COVID. And my lab and others too are trying to, again, leverage what we know from our expertise in different infection models and to see whether or not some of those mechanisms and activities could then be leveraged against COVID as well.
Thank you. And it looks like we have another one for Dr. Catania here. In the Metro Orlando area, is hospital care for COVID-19, is it standardized, especially intubation criteria, or is it variable?
I think that every hospital has their own internal criteria of how to treat patients with a wide variety of syndromes and infections. But the experts in the field consult with the guidelines, and for COVID-19, and I spoke about this in my presentation, there are two main guidelines that we follow, the NIH guidelines and the CDC guidelines. In terms of intubation, there are also critical care guidelines that critical care and pulmonary physicians follow for indications for intubation and other respiratory procedures. I know that early on in the pandemic, there was a belief that early intubation improved outcomes. That was shown to be untrue, and so the strategy now is to try to avoid intubation with all the other non-invasive ventilatory modalities that we have in the hospital, and only intubate at the last possible moment when there are no other options. So the hospitals, to answer the question, the hospitals in the community are not part of a larger task force where we discuss how to treat their patients. There's certainly some presentations and collaborations, but each hospital develops their own internal criteria for these for how to care for their patients.
Thank you very much. And it looks like we have a question for both of you. From either of your perspectives, how concerned, if at all, should the general public be with the, quote, vaccine fast track process? What steps from the traditional track are eliminated or circumvented?
Again, I toss that to Dr. Catania. I mean, I'm more of a bench scientist, and we don't really, I don't really have intimate knowledge of the details of how a vaccine works through all its regulatory hurdles, and perhaps Dr. Catania can better share.
Thank you. I can venture a guess. Vaccines have to be, and any medications have to be submitted to the FDA for approval. Of course, during a non-pandemic process, that is a long process that takes months and years to undergo. And some of it is collection of data, because it takes a long time to collect data on many patients. This is tens of thousands of patients, and to complete those clinical trials. But some of it is probably, some bureaucratic processes that just take time to go through all the different sections. Here, everything has been fast-tracked so that drugs and vaccines, I imagine, and this is for laboratory tests as well, are not really receiving FDA approval, but are receiving emergency use authorization, which means that a fast track, if FDA has deemed that fast track is appropriate in a setting of a pandemic. So they have a different process to make sure that all the they've completed their work in a prompt, but also very thorough process as much as it can be done. So what I would say about the process of current vaccine development, everything has been sped up, but there are still following the phase 1, phase 2, and phase 3 trial schedule like they normally would. So the top 3 vaccines that are being investigated right now, they've all completed phase 1 trials, meaning that healthy volunteers were injected with the vaccines, and in some cases they've had mild to moderate side effects. In some other cases, there may have been a more severe side effect, which is not published, but just reported in a press release. Then after that phase 1 trial, then they go into phase 2 or 3 trials, which now include 20 to 30,000 patients to gather not only the more safety data, but also to really study the efficacy of the vaccine. And that takes a little bit longer to see if you vaccinate someone, whether you have to give them some time to see whether they have a chance to develop the disease, and then you would, if they don't, the conclusion would be that the vaccine prevented that development of that disease. So the phase 1, 2, 3 trial schedule is being followed, but it is done faster, and a lot of bureaucratic hurdles have been lifted to enable performing those faster.
I'd like to add a little bit to that. I totally agree with what Dr. Catania said. There are aspects of clinical trials that can be fast-tracked, and everything about that is good. So for example, if it usually takes 5 years to get 10,000 patients in a trial, and you have to have 10,000 to show that the drug is effective, and you can get 10,000 patients to volunteer in 1 week, you can see how that kind of a change in the process is great. And you get the same amount of information in a week that may have taken 10 years. And that's when you're looking at the numbers of patients that you need to make a trial good. The immediate side effects can also be evaluated in that short term. The thing that's hard to do in the fast track is the long-term side effects. So when you give a vaccine, there are some vaccines that might cause neurologic diseases several years into the future. And those are the things that you can't fast track. You can do 10,000 patients, but if they've only been vaccinated for a month, you can't know what the side effects are going to be in a year. And that's when judgment comes in, and our scientists who look at other vaccines and the time it takes for effects, that's when they will look at it and say, well, ordinarily we'd wait a year to see this, but given what we're seeing now in thousands and thousands of patients, we can make that a shorter time period. And our scientists are watching that. So I think if the question comes out of a fear that if a vaccine is approved, has it been short-tracked and is it really safe, I would listen to people like Tony Fauci, people who are looking at over the entire picture, and if they say it's okay, it's probably okay.
Thank you, Dr. German, and thank you, Dr. Catania. Next question here we have, down the road, will we need both flu and COVID annual vaccines or just one?
Well, go ahead.
I was just going to say that the CDC will be making the ultimate recommendation of what vaccines are needed and recommended in what patients based on their age, underlying medical conditions. So we would wait for that expertise to give us the guidelines as to what would be recommended in the future. I don't think it's known yet.
I'll just add, I mean, seeing as they are different viruses and seeing as antibodies are really specific to discrete targets, I think you will need to generate immunity against both separately. Whether or not they could be combined into one vaccine, like say measles, mumps, rubella, that is something that definitely will require further research.
Okay, thank you. Our next question, is there any relationship between comorbidities like heart disease, their related treatment medications like ACE inhibitors, and COVID disease outcomes?
Yes, there is definitely a relationship between comorbidities like heart disease, even hypertension, obesity, and other underlying conditions, and risk of getting COVID-19, and then the risk of severity of that infection. So certainly there is a definite relationship that has been shown, and different diseases, different underlying conditions have different risks associated. The ACE inhibitors, that's another medication that was early on in the pandemic thought to be associated with more severe COVID-19, but that was based on a few cases that were reported early on, and that relationship is no longer thought to hold. Same story as with the NSAIDs, like ibuprofen.
Okay, and Dr. McKinstry, do you have a follow-up to that?
Sorry, I think that was very well answered.
I do as well. I just wanted to make sure. Okay. If a person was vaccinated against flu in August, should that person be revaccinated in November, given the fact that after 150 days there is effect of that vaccine anymore?
I mean, our vaccine schedules are designed to sort of hit the peak of the vaccine, of the flu season. And so I don't think there's any evidence for sort of a booster within the flu season being more effective than not.
Okay, very good. I understand that the prevalence of COVID is much less in HIV patients than in general population. Do you think that this is due to the therapy they are receiving or related to the virus itself?
So that's an interesting question. Part of how COVID-19 exerts its effect is revving up the immune system and causing these interleukins and interferons to overwhelm the system with inflammation, and especially if that occurs in the lungs. The inflammation in the lungs may be responsible for the lung disease even more so than the damage from the virus. So what has been seen with COVID-19 is that patients who are relatively immunocompromised, not severely immunocompromised, they have worse outcomes, but those patients who have some decreased immune system processes, which we don't really understand very well, they may have a more attenuated COVID-19 infection, and maybe because their immune systems are not overreacting in response to the virus.
Yeah, I'll just chime in that's very true, that the immune system can cause, in some cases, more damage than the infection itself. And so it's really a double-edged sword that needs to be modulated in order to maximize the benefit of the immune system without causing too much immunopathology or systemic inflammation. Yeah.
Great. And this will be our last question this evening. Some of the more severe outcomes of infection have included long-term damage to the heart, lungs, and brain. What do we know about the inflammation mechanism that are leading to these types of organ damage?
Well, I think in relation to COVID, it's too early to tell because we are basically in the phase of interpreting observational studies and so on and so forth. With other viral infections, it is a little bit better understood how a local infection, for example, can spread to other tissues, or how little parts of the virus can spread to other tissues, or how even immune cells that are responding at a site of infection can move to other tissues and begin to cause inflammation. So there are some mechanisms for that kind of spread where you have a localized infection that can lead to systemic effects. But whether or not those particular mechanisms are at play with COVID-19 remains to be fully understood.
Thank you. And if I may just answer the follow-up question about the ACE receptors. So what I wanted to mention that early on there was some discussion, or there were some cases that that brought concern over ACE inhibitors like lisinopril, which is a blood pressure medication use, and increased risk of COVID-19 and more severe COVID-19. And so there were some recommendations that those medications maybe should be held or discontinued if a patient were to come in with COVID-19. That is now not thought to be true, and American College of Cardiology has recommended that patients who need to be on ACE inhibitors should stay on ACE inhibitors, because additional studies that were done did not show that this relationship between ACE inhibitors and COVID-19 is a real association. I understand that there is this potential. Biochemically, it may be possible that ACE inhibitors and NSAIDs may have something to do with ACE receptors, and you know, potentially promote a better binding between the ACE receptor, which is in the lung cells, and the spike protein, which is on the surface of the SARS-CoV-2 virus. So the potential is there, but this relationship or association was not confirmed in additional studies, other than the very few first reports, which are no longer thought to be valid.
Wonderful. Let's have a round of applause. Thank you so very much, Dr. Catania, Dr. McKinstry, and Dr. German as well, for your insights and very relevant information on this topic. We greatly appreciate it. And thank you to all of our friends and our guests for joining us this evening. We're delighted to have you here with us. We look forward to doing future events like this, to share more information about our programs in education and research and patient care throughout our medical school. Some others that we would love to thank on the slide include behind the scenes, we would like to thank Ryan Rutherford for doing our Q&A section. Thank you so much, Ryan, as well as Michael Reeves for all of his help with scheduling our Zoom meeting today and our presentation materials. Also, special thanks to Rachel Backus and Aaron Turner with our advancement team who spearheaded tonight's events. Thank you so very much for that. Following our event this evening, you will receive an email with more information about the UCF College of Medicine and ways that you can get involved in the college. And again, we are so delighted to have you all join us. Thank you so very much for your time. Have a wonderful evening.
Thank you, everyone.
Thank you.
Thank you.